I'm going to focus on the evidence around more than silver technology, but also link that to the wider evidence about biofilm-based wound care and my own experiences in clinical practice around debridements and antimicrobials. You will probably have seen this as a concept. It's a fairly popular concept that's used in clinical practice, and it focuses on systematic assessment of the patient and wound. And without that systematic approach, we will continue to have the failing to heal wound. So systematic assessment of the patient and their wound is crucial to promoting wound healing. And the acronym, or the concept of TIMES, looks really predominantly at the local wound. So it picks up this idea of, is it inflammation, is it infection, or is it biofilm? And the recent addition to TIMES, which has been around as a concept since around 2005, the addition has been biofilm, because of course there's a growing recognition that biofilm is the cause of chronic wounds. So biofilm-based wound care has to be about timely wound assessment, and that takes us right back to the fundamental aspects of promoting wound healing. Timely wound assessment should occur on the first episode of care, not the second episode or the third, but initiating at the first episode. And that may pick up comorbidities that identify from the first point of why that wound is not healing. Reassessment can occur. It will depend on local protocol. In some areas, look at 4-weekly reassessment. Other areas look at earlier and more timely at running it at 2-weekly reassessment. So what does timely wound assessment do? It facilitates early identification of the failing to heal wound. We shouldn't be waiting, as we've already heard in other presentations, we shouldn't be waiting 3 months to then say, oh, I wonder why this wound isn't healing. So it facilitates that early identification of the failing to heal wound. Identifies factors likely to delay healing, and so that's a holistic approach. It's not just what dressing shall I use, it's why is this not working, what's going on with those comorbidities, and what's going on locally to identify why this wound isn't healing. So it prompts diagnosis of wound infection. If we're regularly reassessing that patient's wound, we will be picking up if the patient is developing an infection, which will promote prompt action if they do need antibiotic therapy. And of course it will expedite biofilm recognition or biofilm detection if we're constantly looking at that wound, questioning why is this wound failing to heal. And once we recognise that it's because of biofilm, we can then kickstart those earlier interventions, again, as I've said, rather than waiting for months. And it allows a transition to biofilm-based wound care, and I think that's key in reducing the number of chronic wounds that we have in our clinical settings. So I've looked at the evidence out there around, well, what is biofilm-based wound care? What does it mean? And the key thing that comes up again and again is that we know active debridement, mechanical debridement or sharp debridement is a prerequisite to effective biofilm-based wound care. And that's in a plethora of evidence in the literature. Debridement, how does it work? We know that it influences the microenvironment of the wound because it's physical, because it's a physical degradation of the biofilm matrix. But there's a however there. We also know that sharp debridement or mechanical debridement alone does not provide adequate reduction in biofilm. So it's a temporary measure to remove it, but it doesn't stop it from coming back. And there's evidence out there that we know, and you've already heard from Randy, that biofilm reforms within 24 hours. We also know that topical antimicrobials alone do not eradicate biofilm. And there is an increased tolerance as the biofilm matures. So the further the wound, the longer the wound becomes chronic, the more problematic that biofilm becomes in terms of responding to treatment. Emerging antibiotic resistance calls for a non-antibiotic strategy, so we should be reducing the number of patients that have antibiotics because of the increased resistance. So if that's all the evidence, it still kind of leads us to, well, what's the answer? So when I looked at all this evidence and tried to pull it together, I really believe that the evidence is a partnership, it's a synergistic partnership, incorporating both mechanical debridement to disrupt or remove the biofilm, whilst the topical antimicrobial will continue to destroy the biofilm and prevent that reformation that becomes so problematic with chronic wounds. So what's the secret behind More Than Silver technology? And there are three components that I'm going to spend the next few slides talking to you about. And so More Than Silver technology lies within Aquacel AG Plus dressing concept, which is the first dressing uniquely to hold those three components. So what are they? So the three components is about the disruption in two formats that I'm going to talk about of that biofilm matrix, and then how we can then get in to destroy the biofilm matrix. So the first aspect of disruption is by the use of a surfactant. So the surfactant is built into Aquacel AG Plus and is a cleanser. A surfactant is a cleanser. It's present in products such as skin wipes, and as a surfactant it breaks down or dissolves the surface contaminants as the first part of the process of beginning to disrupt the biofilm. The second part is the metal chelating agent. So what is a metal chelating agent? It's a chemical bonding that acts as a magnet into the biofilm that pulls out. If you imagine biofilm as a scaffold or a matrix of EPS, of polymeric substances, then the chelating agent acts as a magnet to pull out the ions that sit within the biofilm and actually allows that biofilm matrix to collapse, which allows a pathway for the ionic silver to then get to the microorganisms. And so, as has already been alluded to, it's not about the amount of silver that's necessarily in the dressing, but it's about the way in which the ionic silver can actually get to the microorganisms to destroy them. And that's what makes this technology different. And so then there's the destruction. So now that we've broken down, or the biofilm has been broken down, it allows a pathway for the ionic silver to get to the microorganisms. So it ensures cell death of the exposed bacteria, it damages the DNA, it denatures the proteins and enzymes, and it interferes with the protein synthesis. So it's the only way the chelating agent allows the ionic silver to get to the bacteria to be able to do that. So what's the evidence to support that concept? There is evidence in the literature, and I've just chosen one paper to look at because it has significant results in looking at the breakdown of that biofilm. And this was a study in 2014. It looked at 112 difficult to heal wounds, so wounds that were already deemed to be stagnant and chronic, from 60 healthcare facilities across the UK and Ireland. And the local standard of care continued throughout the study, and it looked at all it did was exchange. So the local standards of care continued, and it exchanged the primary dressing and swapped that primary dressing for Aquacel AG Plus. The wounds that were incorporated into that study had a median of about 12 months, but the variation of that ranged from 1 week to 30 years. And even that alone is I find incredible that people are living with wounds that are that chronic. The results speak for themselves, really. The clinicians were expert clinicians. They were asked to categorise those 112 wounds into: is the wound not healing? Is the wound stagnant? Is the wound improving? Is the wound has the wound healed? And of those, the highest percent of those wounds before the experimental study showed almost 80% of those wounds were static, they were stagnant, they were chronic. Okay, and following the study, we can see from the results, bearing in mind that the dressing was the only thing that changed, that 91% of those wounds were either progressed towards healing or had actually healed. So 78% progressing towards healing and 13% healed. So it was an experimental primary research study, and so it's explaining really that there is evidence out there that shows the power of this. So reading the evidence and looking at the issues around debridement and antimicrobials led me to look at developing a protocol of care in clinical practice with the concept of cleansing, debriding, cleansing, and then going on to manage. So the concept of that lay with using the surfactant that we've seen in practice works to break down the surface contaminants, but then to be slightly more aggressive using a curette. So we call this now the process of curettage, and it fits into the protocol or algorithm that I've recently developed following gathering the evidence from my dissertation. So it looks very much about we must be more active in identifying the failing to heal wound. We've looked at what's recorded in nurses' documentation, and time again there's a pattern of wound is healing in terms of what's being recorded. 3 months later, 6 months later, wound is healing. The wound is not healing if that's the duration of the wound. And what we need to be much better at is writing and recording so that we can see the patterns is what is the duration of this wound, rather than being a little bit task-orientated in managing those wounds. So is the wound failing to heal at 4 weeks or earlier if that's deemed appropriate? And if it's failing to heal and yes is the answer, then we can look at factors affecting healing holistically. Are there comorbidities that are influencing that wound, or are there local factors that are influencing that wound, which of course takes us then down to are there clinical indications of biofilm? So if there are clinical indications of biofilm, then we move into that management strategy of destroying the biofilm, breaking down the matrix and managing that biofilm, stopping that biofilm from returning. That begs the question of clinical skills, and do nurses have the clinical skills to make the decision at the ground level to, I'm going to take a curette to this wound and start to slice through it? And clearly the answer is no, and I'm not advocating that curettage is the right protocol for every nurse to go forth and sharp debride. But equally, we can be too cautious and end up with wounds that are chronic and not healing. So it's this mixture of, is the clinician clinically competent to debride with a curette? And if not, then a referral will be made to the competent clinician. And in the meantime, there are other methods of more conservative debridements using debridement cloths, for example, but it's still only an interim measure. So the sharp debridement is the key to this process, really. So the impact of working with that concept and working with Aquacel AG plus Extra in clinical practice alongside curettage did mean that we amended our wound care formulary to Aquacel AG plus Extra. We're seeing, and it's phenomenal, and we have to capture this in data, but we are seeing increased healing rates. And I'll show you with the final 3 case studies that I'll finish with. We are seeing longer wear time for the patients. We're seeing reduced strike-through in odour because we're combating the problem that's causing that odour and those high levels of exudate, which of course is the biofilm. And we're also seeing consistency in clinical decision-making. We're seeing that growing of awareness by being out there working with clinicians, teaching them about biofilm, teaching them about curettage safely. So I've got 3 examples to show you that is really hopefully quite thought-provoking. This was my light bulb moment. This was my first patient, having read about biofilm and the need to debride and getting more and more excited about that I was able to take this really into clinical practice. And this was my light bulb moment when I looked at this wound and read around all there is to how do we diagnose biofilm? How can we see that this slime, shine is biofilm? And when I looked at that, my gut instinct was this is biofilm. And this patient had no change in her wound for 3 years. So the nurses were going in, she had every type of dressing going within that 3 years. She was having modified compression. So she had rheumatoid arthritis, but it was safe to apply modified compression based on assessment. So we started curettage and Aquacel AG plus Extra as an interim, and we curetted this wound every 2 weeks. So it's not a daily requirement, but there does need to be an evolving pattern. So 2 weekly initially, and then maybe moving on to monthly, but it's certainly a pattern that we're seeing in practice. So it's not weekly because that's a huge impact on resources for those nurses who can use a curette. So we saw healing within 3 months, and that meant this was evidence for me, and I know it was one case study, but it was evidence for me that made me take the curette much more bravely into clinical practice. And along came this lady with a referral who had multiple comorbidities that were being addressed. So she had diabetes that was reasonably well controlled. She had lymphedema that was being controlled with compression hosiery. And it wasn't until she sustained a trauma injury and a hematoma that we started to get wound chronicity back again, partly because of her comorbidities and partly because of the biofilm that was present. So again, this wound had been present for a year, and following debridement of the hematoma, nothing changed for this wound. So again, you can see from looking at it, the slime, the shine, that it was biofilm. And this removed very successfully within the first episode of curettage, following which there was subsequent episodes of curettage around every 2 weeks, but in between, again, using Aquacel AG plus extra. And even within the first month, there was rapid healing of this wound. So the patient and I were both getting equally excited about this, because it's, we have to carry on. And so then we've got that, you can see the shape of the wound starting to take shape, really. And in February, it's almost there. And then within 3 months again, we've got the virtually healed wound. And I think that's crucial to actually capture that and build the data of those kind of case studies into, can we really prove that we can get healing within a 3-month episode for patients who have had wounds for years? And that is a pattern that we're seeing. And that's supported in the literature as well, that with the right treatment at the right time, then we're looking at 3 months for chronic wounds to begin to heal. And my final case study is my pièce de résistance, really. I'm still seeing this patient. I'm still curetting every couple of weeks. And it is taking longer, but he had this ulcer for a lot longer. He's only 66. He was diagnosed with rheumatoid arthritis at the age of 26. So a huge comorbidity influencing this chronic wound. Right fixed ankle joint, so some links there with a limited venous return. He'd had this ulcer since 2011. He also had a toe amputation in 2017, so it led people or clinicians to believe, well, that must be because of reduced vascularity, he can't therefore have compression. So we did put him into compression and initiated the curettage. So it was 2 weekly alongside Aquacel AG. And the results are slower, so I'm not guaranteeing a 3-month healing rate with this patient, but we began to see the changes in the shape of the wound, and the patient began to see those changes. This patient was going to bed with a bin liner on his leg because of the strike through, because of the exudate. So a huge impact on his quality of life. So you can see the wounds shrinking, and the patient themselves would tell me every time I saw him, you can see that it's come up a little bit more on this side, because it was a circumferential ulcer, so he was trying to see all of it to get the picture. And this is where we are today. And even seeing him a couple of days before travelling here today, it's actually even smaller, so I just didn't have time to capture it. So a huge impact on his quality of life. And he was told that his wounds would never heal, and that was something he would have to live with. And I don't believe that, because his wound will heal. And as I say, I am continuing with curettage and Aquacel AG. Okay, so we know that there's a huge health economic burden around the management of chronic wounds. In the UK, there's evidence to say that we're spending $5 billion annually on the management of wounds. And Guest did that work in 2015 and has also gone on to look at other cost analysis. And he wanted to look at what costs were attributable to the management of acute and chronic wounds among a catchment area within a community. So a population of 250,000, which is quite typical of a clinical commissioning group population. And they found 11,000 wounds within a population of 250,000, which is astronomical. 40 were acute, potentially going on to become chronic. 48 were chronic, and 12% were undiagnosed, again suggesting that those undiagnosed patients were not having a wound assessment. The cost of a healed wound ranged to a maximum of around 4,000. The cost of an unhealed wound was around 6,000. So huge cost, a huge burden on healthcare resources. And we have to see an increase in those wound healing rates across all wound types, across acute and chronic, to slow the rising prevalence of wound chronicity. Okay, so to summarise, with biofilm management strategies and wound chronicity, we know that biofilm is present in up to 78% of chronic wounds. It's the crux of why wounds are not healing. We know that biofilm creates a substantial and ineffective inflammatory response. It also impairs granulation tissue formation and the development of epithelialization. Chronic wounds don't get there while there's biofilm present. They don't get to that stage of epithelialization. Biofilm is tolerant to antiseptics and antibiotics. And chronic, as Randy said, chronic wounds are chronic infections, and we require new strategies. And new strategies are required, and they have to be based on a biofilm-based wound care approach to eradicate biofilm. So it's a battle. So the future of chronic wound care, what does the future of chronic wound care bring? It brings an antimicrobial, or it calls for an antimicrobial stewardship. To prevent antibiotic overuse, and that's evident in the literature. We should be reducing microbial resistance, hopefully, and through the appropriate use of antimicrobial dressings. We should be calling for national guidelines. We should be looking at developing protocols locally and nationally. You've seen 2 different types of protocols within these sessions. And we're calling for prompt action within this concept of cleansing, debriding, cleansing and managing to stop that biofilm from coming back or from redeveloping. Hopefully, the long-term outcomes will see improved outcomes of reduced infection, fewer amputations, which is a huge issue, faster healing, and for the patient, which is just so immense, is a better quality of life for those patients. And health economics. Okay, so cost savings, reduced NHS burden, and hopefully moving towards a more appropriate use of those resources. And I think that leaves me with my final question, is to say, why are we waiting? Why are we not moving this forward?